Welcome to today's webinar, Integration of Behavioral Health Care Coordination in the Primary Care Setting, provided through a collaboration between the Pennsylvania Medical Home Initiative, a program of the Pennsylvania chapter of the American Academy of Pediatrics, and funded by the Pennsylvania Department of Health. This webinar, led by Dr. Schlesinger, Dr. Turchi, and Colleen Gianeschi, aims to evaluate the impact that care coordination has already had on patient care experience and outcomes, to apply existing physical health care coordination concepts and strategies to patients identified with a behavioral health care need, and to expand knowledge of the behavioral health care system, including different levels of care. I am Eileen Thompson, the Program Director of the Pennsylvania Medical Home Initiative at the Pennsylvania chapter of the American Academy of Pediatrics. This webinar is being recorded. The recording will be available on both the Pennsylvania Medical Home Initiative website and will be posted on the University of Pittsburgh Internet-Based Studies and Education and Research website. For CME purposes, please be advised that none of the speakers today have any disclosures. Please note that the information presented in this webinar is educational in nature and does not necessarily represent the views or policies of the Pennsylvania chapter of the American Academy of Pediatrics or its funders. Now allow me to introduce our presenters for today's webinar. Dr. Abigail Schlesinger is Chief of the Behavioral Science Division at UPMC Children's Hospital of Pittsburgh and Medical Director of Children's TIPS, Telephonic Psychiatric Services. She is the Associate Service Chief of Child and Adolescent Ambulatory Services and the Medical Director of Integration at UPMC Western Psychiatric Hospital. She is also an Associate Professor of Psychiatry at the University of Pittsburgh School of Medicine. Dr. Schlesinger helped create Children's Community Pediatrics Behavioral Health Program, which provides early access to integrated behavioral health services right in the pediatrician's offices. She's devoted her career to improving how we talk about and treat mental health issues. Dr. Renee Turchi is Section Chief, General Pediatrics and Medical Director of the Center for Children and Youth with Special Health Care Needs at St. Christopher's Hospital for Children in Philadelphia. She is Medical Director of the Pennsylvania Medical Home Program at the Pennsylvania chapter of the American Academy of Pediatrics, a statewide quality improvement program for pediatric practices across Pennsylvania funded by the Pennsylvania Department of Health and the Maternal Child Health Bureau. Dr. Turchi is a professor of pediatrics at Drexel University School of Public Health and College of Medicine. Her research and clinical work around care coordination and children and youth with special health care needs have been presented and published in multiple national forums. Colleen Gianeschi is a licensed clinical social worker and program manager at the Children's TIPS program. She is also a behavioral health therapist at the Children's TIPS and Child and Family Counseling Center at the Children's Hospital of UPMC and is an integral part of the program. We are so delighted to have Dr. Schlesinger, Dr. Turchi, and Colleen Gianeschi present on this timely and important topic for primary care clinicians. At this time, we will begin our presentation.
Thank you, Eileen. This is Renee Turchi for that introduction. Excuse me, and thank you, Dr. Schlesinger and Colleen, for being part of this presentation today. We're thrilled to be talking about behavioral health and the intersection of behavioral and physical health. So today we wanted to cover the impact and the relationship of care coordination and think about how it's already informed for many of us in the medical physical health side, that patient care experience, and talk briefly about some of the outcomes. And then we want to take that physical health care coordination paradigm and think about how that informs and works to help identify and address the patient and family needs that we work with and their behavioral health care needs. And we really want to then really focus on, Dr. Schlesinger and Colleen, that knowledge of the behavioral health care system, including the various levels of care. I'm excited to address these objectives. So I wanted to just take us back for a minute and think about those definitions. As care coordination and care integration has become such an integral part of the work that all of us do in the primary care arena. And this definition of pediatric care coordination, I think, really highlights and underscores some key constructs. including that patient and family-centered, assessment-driven, team-based activity that truly is designed to meet the needs of children and youth while enhancing the caregiving capabilities of families. So truly recognizing in that definition, one of the key points is that we're building on the already existing strengths of families and patients that we work with. And the other key piece that I think is very salient to the discussion we're having today around that intersection and integration of behavioral and physical health is that interrelationship between the medical, social, developmental, behavioral, educational, financial needs of the family and patient really help us think about the optimal potential and wellness of a child and family. So when we think about care coordination, we know that while many of us agree that this is an important concept, many of us are doing it every day, I think it is really important to also recognize that this is an evidence-based practice that's had a great deal of research done on care coordination and integration, both in the primary care and behavioral health arena, and thinking a lot about its impact in healthcare. And so these are just a few of the articles and studies that have been done recently, but we know that care coordination lowers healthcare costs, that it improves patient and family outcomes in care, addresses things like family experience, patient experience, and so we know that that's improved in satisfaction scores. And we also know that, when we look at the patient-centered medical home standards, whether you're talking about the National Committee of Quality Assurance, and even right here in Pennsylvania, when we work with our own Medicaid, that patient care coordination, family care coordination has been shown to really hit all of those elements and has been recognized as a key factor in the value-based healthcare arena and quality healthcare arena. And we certainly know that when we talk about, and then I turn this over to Dr. Schlesinger and Colleen, that the care coordination is very relevant and salient and addresses all of these issues, not just in the physical health but behavioral health care arena. I just wanted to briefly highlight, many of you in the Medical Home Network have seen this care map before, but I just really want to highlight, I know that you might say, wow, these ovals are hard to read, and really the point of this slide and sharing this slide is that when I think about care coordination, it really is not at all useful or effective if it's not incorporating that patient and family perspective. And so this care map that's actually was drawn by a parent of a little guy named Gabe, when you see that sort of central circle of her family, the real point of the slide is just showing all these various ovals that Gabe's mom and these different arenas that she highlighted in drawing what a day in the life and what are the needs and players that play a role in Gabe's family. And when you sort of look at those various areas of color, you can see the healthcare arena, the advocacy arena, the legal arena, and really I think the key here is that the medical primary care is just one of those many ovals. The behavioral health is just one of those many ovals. So this just helps to underscore the real value of care coordination and integration and how we have to think about how families are coordinating not just the care that they're receiving in our offices, but that this really underscores the various players, a coordinator for the coordinators, and really helps us see through the eyes of families all the needs and folks that are involved in their life to help their family. So thinking about, those care maps and thinking about, from the provider perspective, so from where we sit in offices, recognizing that, this collaborative interdisciplinary care really helps us think about the plan of care, the treatment that's needed for our families. And so when we think about that general plan of care and thinking about that as the central piece and looking at whether you're sitting in primary care, behavioral health, through the eyes of the patient or family, education, community partners, there's many circles that aren't even represented on the schematic we present here, but that it's important to remember that the collaboration that we all do and the collaboration that we talk a lot in the medical home arena can be, through discussions, letters, written plans of care, care maps like I just showed you. It also could be informal ways. So it might be that you're looking on, the health information exchange or your electronic health record, looking at notes, or maybe at staff meetings or patient huddles before clinic or patient care time or phone calls with providers. But recognizing that a designated care coordinator really helps look at and work with that patient and family, does, a goal-driven needs assessment, looking at the family and patient strengths, and really having this driven by what the family needs, not just in the home arena, but in school, in the community, thinking about this child being, a functioning member of their world and their community, both at home, playing soccer, transitioning to adult care. And this plan of care is central to accomplishing that. And this just word cloud really highlights, I think some of the key pieces that we often talk about with related to care coordination, thinking about those elements that, are written about in policy statements, the family-centeredness, the comprehensiveness, thinking about, care coordination occurring from the time a child may leave, let's say, the NICU, to being in school, behavioral health, going to adulthood, but there's many elements to effective care coordination. Taking us back to sort of the policy world, thinking about, brilliant Don Berwick, who coined this idea of the quadruple aim. Many of you may have heard of the triple aim, but, we now talk more about the quadruple aim. And it's really this idea that in order to achieve effective health care, we need to be thinking about these various elements. And so that really, looking at population health, so thinking about whether, we're working through our offices, through registries, with our payers, looking at high-risk patients to improve the population health of our patients so that we can affect favorably costs as well as affect, as we mentioned earlier, the patient and family experience. So that if we're doing this, in a coordinated, effective manner, we should have satisfied patients and families. And those were the first three sort of triple aim that many of you may be familiar with. And very recently, folks have added that fourth aim, the quadruple aim, hence the name, is satisfied providers. Because if we think about our experience, and many of us are working in healthcare or behavioral health because we love working with patients and families, but having a coordinated, orchestrated system that's functioning at a high level and looking at, quality improvement, looking at population health, if we can coordinate more effectively with our behavioral health colleagues, have streamlined communication, can have improved access, we will have more satisfied providers and clinicians that are more likely in our offices and in our practices to want to stay, have job satisfaction, look to improving healthcare, look to innovative ways to make the system even better. And this extends, and when I say this, really includes clinicians and physicians and PAs and nurse practitioners, but also all of our office staff. It's critical to think about, satisfied team members. So whether that's your front staff, your care coordinators, your medical assistants, if we're thinking about achieving effective healthcare transformation, this extends to all of our team-based care. I wanted to also just highlight for you on this webinar the American Academy of Pediatrics policy statement that was recently released a couple of years ago that still has a lot of salient practical tools on the patient and family-centered care coordination, really provides a framework that underscores, families driving this process and really underscores the multiple systems within which care coordination lives. So encourage you to take a look at that or for that if you haven't already. And in that policy statement, there's a lot of discussion about care coordination and some constructs. And one of the things I often think about in my own practice is, a busy patient day where your team's working, you're humming, you're helping families, and you're loving working with all the little people that come through and you get to spend time with. But often that care coordination, occurs in the visit, but I often find in my own practice that space between the visits, or that space between when a child or youth is discharged from the hospital and they land back in my office for post-hospital discharge follow-up, where I'm working with my nurses or my community health workers and team to coordinate that care, that often is where the thrust of care coordination is occurring, in that time in between where maybe I prescribed a medication that wasn't covered, so a prior auth is needed. Or maybe we determine that a child does need home nursing services, so now we're writing a letter of medical necessity, and our team is working with, special needs units to get that approved. So recognizing that set of activities that occurs outside the walls or that half hour, however long you're in the visit, is really often when a big bulk of that care coordination occurs. And that's really important because that's how you think about operationalizing the work we do and why communication and collaboration with our partners is really key, whether that's done in person, electronically, over the phone. And also recognizing, and we talk a bit about this in the policy statement, is that taking care coordination and thinking about integrated care. And that really is relevant to when we're talking about behavioral health. So that you're really taking that coordinated care and you're getting those health care and behavioral health services, again, driven by the family, looking in that continuum and looking at that interdisciplinary care. There's no boundaries. There's no walls. That I'm coordinating care and integrating that care with Dr. Schlesinger in my office, looking at, it doesn't matter that she might be in, a behavioral health site off-site, or, maybe I don't have co-located services in my office, but I'm still able to integrate care for the patient in front of me to really help achieve what that child needs. Maybe we're both informing his IEP. Maybe we're both working together to make sure we're not duplicating services, but we're taking that coordinated care that occurred between the visits, and now we're integrating it across multiple disciplines. This is an example of some data, and without belaboring the whole study, but I thought this was relevant to share because this actually came from the Medical Home Network. Several years ago, we published a study. Many of you that are on this call today probably remember doing this, but we had we used a care coordination measurement tool. We had 23 practices in the Pennsylvania Medical Home Network that are part of the American Academy of Pediatrics. And one of the things that we did with those 23 practices was that we had the care coordinators track care coordination encounters. And through that, we looked at every interface within a registry of complex care, and we had them track the focus of their care coordination, the amount of time that it took to coordinate that care, where it took place, who they were connecting with, and what the outcome was. We're doing lots of analysis on that data, but I wanted to share this slide with you because I think it highlights what I mentioned earlier, and this comes right from our own Commonwealth of PA and our Medical Home Network, that shows that in this particular analysis, we pulled out children that had asthma. And what we did was if you look on the horizontal axis, it says days and epic. Really what that means is the amount of time that they were getting coordinated care, the days that they were engaged and had those care coordination tracked. And the vertical axis is the emergency department visits. And what we did was we pulled out those children with asthma in that cohort of 80,000 different care coordination encounters amongst about 16,000 children among 23 practices, and looked at kids that had various severity levels of asthma to look at what was the association of coordinating care for those cohorts of children that had asthma. And we divided up, 1 being a sort of lower severity of asthma and 4 being the most severe. And what this graph really shows is that if you look across all severities of asthma, there was a statistically significant decrease in emergency department visits with more of a dose of care coordination, if you can sort of think of it that way. So the longer and more care coordination they got, we definitely saw that, there was an association with decreased ED visits. And actually, the most, while that was statistically significant for all asthma severity scores, it was most significant for children with the most mild asthma, that severity score of 1 there that you see at the bottom. And, I've thought about this a lot over the years, and I think this makes sense to me because when I think about it, and for those of you, in practice, think about it, it's those children with asthma that maybe show up to the ED that perhaps maybe just hadn't come to your office, they didn't get their inhaled corticosteroids, they missed their flu shot, they didn't have an asthma action plan, that we were able to most intervene and move the needle with the most. Those were kids that we brought in on a registry, maybe had a home visit if you were working with an environmental remediation plan, and we were able to most dramatically affect those children because it was getting them into our office, improving access, improving linkage, getting them inhalers that were covered by their plan, that we were able to impact their ED visits. And we still impacted those kids with most severe asthma, but what it says is that, you could be really plugged in to your care coordinator and your medical home, but it might be that you have a child who has such significant asthma, they're on, they have a home ventilator, that, when they get the flu, you might be able to have it, decrease a couple of ED visits, but the truth is that for some kids, we're not going to prevent all admissions or ED visits for some children who are so severely affected by their underlying lung disease, they may in fact, some kids may just need that admission with, continuous albuterol or IV steroids. But it tells the story to me that, we can look across severity and say, regardless of severity, care coordination has a role for a very common diagnosis with asthma as well as others, and we can show with our data that it has moved the needle, that it has favorably impacted families, and that it has favorably impacted cost and quality of care. And I wanted to share that data because you guys generated this. So I wanted to shift now into the feedback and turn this over to Abby and Colleen. And one of the things I wanted to share, and many of you, some of you that are on the phone may know this, we wanted to, we thought about and we really worked on this webinar with a lot of feedback from the medical home practices. And many of you are using the TIPS program and the telephonic psychiatry, and for which Dr. Schlesinger has really been spearheaded her team in doing that across the Commonwealth. And we wanted to have a sort of practice, informed kind of look at what are some of the behavioral health care coordination challenges that many of you are experiencing in practice. And Arlene Thompson, our program director at the chapter and for the medical home program, did an awesome job collating some feedback from our various practices, that we solicited some feedback. I'm sure there's more, and we certainly know that a lot of us are addressing these issues, but we've had some idea about what some of the challenges folks are facing, but we really wanted to hear directly from our practices. And so when we kind of looked at the feedback we received over the last couple of months from many of you, sort of fell into, what we determined these categories. Challenges, in looking at behavioral health care coordination, folks really talked a lot about access issues. And we'll dissect that and share some of those specifics, and Dr. Schlesinger will try to, speak to some of those. Medication challenges that folks are experiencing on the ground, as well as resources and accessing resources, and certainly issues with insurance and payment. And so what we're going to do now is kind of maybe go through some of those specific challenges. And really, the purpose of today's call is not to go through challenge by challenge, because we could probably spend a whole conference day going through specific issues that each of us are having. But we wanted to sort of start the conversation, talk about from the practice perspective what some of the issues we're having. And Dr. Schlesinger and her team and Colleen have lots of ideas, but we also know that they while they're here to help us think through some of these things, they're not able to change everything and address every single problem. But we wanted to kind of frame some of the discussion with some of what many of us are experiencing in practice. So with that, Dr. Schlesinger and Colleen, I'll turn this over to you.
Thanks, Dr. Turchi. This is Abigail Schlesinger. Thanks again for having me have the opportunity to present to this group. I think that I'm also thankful for Eileen and Renee for collecting this information from the practices. Although TIPS and the Medical Home Initiative have worked close together for several years now, I agree. I think this is the beginning of us starting to think about how can we really take off in terms of supporting more care coordination, supporting more of the training that you all might need. And I want to remind everyone that if any of these questions you need to have answered in a more thorough way in your practice, that any of the TIPS providers can come to your practice and would love to come to your practice to do more education about any of these things. And thank you for putting these together into sort of these 4 buckets. And I'm going to respond briefly to some of these items on each of these lists, and also some of them will be addressed in the upcoming slides. And in the end, there'll be an opportunity to ask more questions if you want to or for clarification. As Renee said, Dr. Turchi said, I wish I could correct all of the problems in the entire healthcare system, but we can't. And if we try to, as physicians, as providers, we end up burning out. So, what we all need to do is figure out what we can control and do our best to improve it, which I think is part of the reason why all of your practices are in the Medical Home Initiative. That's certainly why I work with you all. A couple things on here I wanted to address specifically before we get into the levels of care issue is, the BHRS question is an interesting issue. The data for BHRS is not that good, and there's been a significant push across the state to get other more evidence-based interventions in place. So sometimes when you can't access things, it's actually because there's a push in the state to get other more evidence-based initiatives in place, which is why it's hard to stay on top of what's going on. But I think that I want to get it back to the idea of intersection, that Dr. Turchi mentioned before, that behavioral health and primary care really do, and medical care really do intersect. And the more we all try to learn about each other and do a better job, I think the better we help our families. And in fact, that asthma data just shows it so well. I completely resonate with the IEPs and 504 plans. I think some of these issues related to same day and number of calls and lag time for therapeutic services is an issue related to boundaries and urgent versus emergency, which I know is not as clear for behavioral health as it might be for a fever or for someone that needs to go to the hospital. And I think that's something that we've really been coming to grips with in our primary care groups over the last few years. How can we do a better job of making sure people are educated about what the difference is between an emergency and an urgency, or a perceived urgency even? And how do we help our pediatric colleagues? We've even been talking to the trainees about learning about boundaries earlier, how to set boundaries in a way that's appropriate and healthy for families and for themselves, so we can really hit that quadruple aim and not only the triple aim. And then Dr. Turchi put this nice information here about how Dr. Hubbard at Reading Pediatrics actually engaged a state senator to get more help from the legislator about issues related to primary care intervention. The no evening or weekend appointment, man, I wish I could fix that. It's not that there's none. It's that they're not as available, and they're less likely to be available for Medicaid, people that have Medicaid, unfortunately. So that is a reality. I think that I have certainly heard pressure across the entire system, and I speak to behavioral health providers quite a lot as well, beginning to think more about after-school appointments, after-work appointments, and having more availability. So I hear a lot of talk about that. I've seen improvements, but that's an ongoing thing we'll struggle with. So medication challenges and prior auths, man, I wish I could just wipe those off the planet. I can't. But I know there's a number of initiatives going on in the state to take a look at prior auths. That both AAP and the Child and Adolescent Psychiatry Group have been active in getting the state legislator understanding the issues related to prior auths. And I think that the high deductible plan and cost of medication, if in fact a child qualifies for PH95 or what's commonly known as the loophole, they don't have copays. So we're going to go in later into that PH95 issue so you can understand that better. We'll have a couple slides on that. And then mail order and 3-month supplies isn't actually necessarily only mental health. So I'm not going to address that specifically related to mental health. So obviously we all struggle with resources on a daily basis, and I've really been just continually happy with what we've been able to do with the Medical Health Initiative to try to take on some of these issues and get more education out there, get more quality improvement things out there. And I think over the next few years we'll even have more opportunities to do specific trainings or quality improvement initiatives around supporting practices to provide mental health services. I did want to add the autism diagnosis is difficult to obtain for patients. I know that's true, and there's been lots of sort of cool things that have gone on in this state to try to help with that, including getting primary care providers trained to do autism assessments, which is really rare, but is being done in our state. A point I wanted to highlight there is that they're really, it's amazing how many calls I get where pediatricians say, I'm convinced this kid has autism, but everybody's missed it. And sometimes they're correct, and sometimes it's that the kid is falling right outside of the autism range. We know that those kids struggle as much, if not more, than the kids that have autism because they don't fit in any specific service. And I just wanted to highlight that it's not just that first time eval. It's some kids, the way that ADOS is set up, they need to come back for multiple appointments. They might need to come back in a year to see how they're progressing, to see if they've sort of fallen off of expectations. And what I really see is because it's so hard to get that initial evaluation, people don't come back for that second or third evaluation. And that's something that care coordination can really provide, and that pediatricians can really encourage, or family practice doctors can really encourage, that if they think a kid has autism, they should send them back to get ongoing evaluations. At the very least, please don't wait until someone has a diagnosis to get them intervention. I think we all know that about early intervention. If a kid's not talking, we get them early intervention. But if kids having significant behavioral difficulties, please don't wait for a diagnosis like autism to get them intervention. We really need to start early. And then there's a lot in here about relationships and using tips. Continue to use tips. I heard another great story today about a practice in Reading that's using tips and happy with it. And I'm going to share that with my Hershey colleagues. And then there's insurance and payment. So it is true that in our state, unfortunately, although the behavioral health and physical health world intersect, and we know the mind and the brain work together, as I often say, the brain runs the show for the rest of the body. Unfortunately, payment is segregated and is not probably going to stop being segregated at any time in the near future. So we do need to accept these different payment structures and understand them. And maybe this may be another opportunity in the future for us to do some more education. The issue about Medicaid not allowing patients to be seen in practice, I believe that's referring to the Stark Law. That is an issue. I totally agree with it. We run into it frequently, actually, at Children's, where we're constantly having to go to our legislators to push things through. And we have advocated at the state level to reduce the sort of restrictions related to that, because it really goes against the whole idea of what we're saying with medical home. Unfortunately, the legislature runs like sort of behind with what's really going on in the world. And as it mentions, grants are short-lived, but I've seen a lot of great things that practices have done to either co-locate a provider, integrate a provider, or develop a relationship with their community providers. You know, the behavioral health providers claim that they're dying to develop relationships with pediatric practices. I would say my experience is that's true, but oftentimes they don't know how to do it, and they're not often sure of what your needs are. But starting the communication can really improve the process. Obviously, though, once you start the communication, there'll need to be ongoing manipulation to continue to improve, because oftentimes the behavioral health providers and the PCPs are coming from different places in terms of the level of behavioral health issues they deal with, or their understanding of behavioral health, or from the behavioral health perspective, their understanding of what PCPs do, where they fit in the system. So simply communicating isn't going to fix all the problems, but it does start you on a path towards improving care, which I believe all of you are on that path already. And coding for behavioral health services, there are people that make lots of money on that, ironically, training people to that. But that might be another opportunity in the future for us to work with you. So I'm going to hand off to Colleen Gianeski to talk about behavioral health levels of care. We have this on here because we've gotten many questions at many of the in-person events we've gotten about that behavioral health levels of care. And it took us several years to figure out sort of how to put together something to be useful. I think we've started to sort of scratch the surface to give you all some basic ideas about levels of care within your practice. So I'm going to hand off to Colleen Gianeski for a few slides here.
Sure. So the triangle, I think our intention here is to show that, just like physical health and the medical health, it's not a one-size-fits-all approach, and so we have multiple levels of care in behavioral health. And I think when families are coming to you, maybe with some frustration, it could be that they may be in the wrong level of care. And our hope is if you're aware of the different levels of care that may be available in your county, that you might be able to advocate for those families for more services, more appropriate services that actually meet the acuity of that child's presenting concern. So at the bottom, you'll see most of the kids will be seen in a primary care or outpatient setting. When I talk about community-based services, I'm talking about those that happen actually in the home, school, or community. We'll go into a little bit more about those. We have intensive outpatient programs. We have partial hospitalization programs. Those are clinic-based and sometimes school-based. We have residential treatment facilities, diversion, acute stabilization. And the highest level of care there, obviously, is inpatient. And then I have on the side there the case management, because that person, when people have case managers or resource coordinators or intensive case managers, they can really work with all of those levels of care. So we went ahead and put it on the outside just to show that they kind of can coordinate all those services.
A couple points I wanted to make about this slide is we use the triangle for a reason. It's true, very few kids end up in the hospital. Thank goodness, right? But when things get scary, oftentimes I'll get calls saying, I don't understand why this kid's not here, or they got not in the hospital, or they got discharged and they're still ill. I have to be really honest with people and say that hospitalizations are really brief these days, so kids are getting discharged on their way to better. It's true on the medical side as well as on the psychiatric side, but I think because we understand less about the psychiatric side, it can be a little more scary. I really encourage you to think about those kids that get stepped down from inpatient. Many times they're starting behavioral health service, but they don't have a psychiatrist yet. Those are the patients that are certainly ripe for tips to help you all so that we can do our best, because we know that people are actually most at risk those first 2 weeks. No matter how long they stayed in the hospital, even when hospitalizations were months, they were still most at risk the couple weeks after they got out of the hospital. Same true for residential treatment. So please use tips when you hit those periods, and I think the more you can know who's in the hospital and reach out, even better. There are diversion and acute stabilization across the state as well as residential treatment, although I have to say there are increasingly less beds of those available as well, and that generally it takes going over a mountain to get residential treatment. Oftentimes it requires bringing your community partners together, which we're going to talk about who your partners are in the upcoming slides.
So the next several slides, we've broken down each level of care just to give you a little bit better idea of what those levels of care might look like. I think most of you know what individual therapy would look like. We included some different evidence-based interventions, like Dr. Schlesinger had mentioned, some of the community-based that may not have as much evidence to support. We're really trying to push people into evidence-based interventions so they get the right treatment at the right time. So we added a couple things like parent-child interaction therapy, cognitive behavioral therapy, trauma-focused CBT, EBT. These are things that to be listening for when families are coming in and talking about outpatient therapy. Trying to figure out if they are getting an evidence-based intervention. These are the words that we would want you to be looking for. Now, these certainly are, we have not been able to hit all of them, and Dr. Schlesinger added in there that these are of thousands of evidence-based interventions. But these are the ones that we often, through tips, are making recommendations for. There's usually several trained clinicians in your communities in these areas, so we just wanted you to be aware of those. Family therapy, although most individual therapists will also incorporate or should incorporate family into an individual treatment plan, family therapy is where the treatment plans are really focused on the family dynamic. And so people can get both individual and family, although the family therapy, there has to be an identified patient, and sometimes that needs to be someone different than who's in individual therapy. And then group therapy is just that, where there's a group that's happening. It's typically 1 day a week for about 1 hour, and they're typically trying to get kids with a similar diagnosis or presenting concerns, and really targeting the intervention in a group dynamic.
A point that I often make to people is that there are mental health centers and then private outpatient providers. There are strengths and weaknesses to both, but something important to recognize about something that's baked into the mental health center concept in Pennsylvania is this idea of someone being an active case or not an active case, meaning a patient that's been there consistently or one that's dropped off. And because they're really measured by their active patients and by their ability to close charts when someone's not active, you may see kids that fall off of mental health centers' roles because they disappeared over the summer. We've advocated against that. We're not winning that battle. Private providers have a little bit better way to do that, but it's a nice thing to advocate for your patient to say, even though they might seem better over the summer or over Christmas, that they should stay active because it's perceived as a quality measure within the mental health center area. So they really want to stay alert to who's in their treatment so they can make sure they're doing well. That's the reason why it exists there, but it's something important to know as a behavioral health, as a primary care provider.
The next slide talks about a little bit higher intensity of outpatient services. The intensive outpatient, sometimes it's used as a step down or a step up level of treatment. It's typically about 3 to 4 days a week for about 2 to 3 hours. A lot of communities will have these either during the day or after school, and kids typically stay in the IOP for somewhere between 4 to 6 weeks, and obviously that varies based on acuity. The partial hospitalization, or PHP, is usually a 4 to 5 day a week program. They're typically school hours, and they're usually getting some instruction for their education, as well as the individual and family and group therapy. And those average lengths of stay are a little bit shorter, somewhere between 3 to 5 weeks.
It's important to know that partial hospitalization program is mandated by the state to have an on-site psychiatrist who sees the patients. IOP is mandated to have a relationship with the psychiatrist, so the patient doesn't need to be seen every week. And groups has no mandate. So someone that's in a group, even in a behavioral health center, may not be associated with a psychiatrist.
And the next one, to address some of the barriers, is that, in the state of Pennsylvania and many other states are providing behavioral health services actually in the school. So, we wanted to make sure that you were aware of those. I started with the student assistance program because I think it's important when families are coming to you and mentioning maybe a new concern or maybe an existing behavioral health concern that's really impacting that child's education, that we could be asking, are you aware, have you talked to the school? Are you connected with the student assistance program? And I put a link in there for more information because I think SAP is a really important resource that we want to make sure that families are aware of and are asking for when they're really struggling in the school and home. The next one is school-based therapy, and this was where they're actually putting behavioral health therapists in the school setting. That way, families, if there's transportation barriers or addresses the after-school or evening hours or weekend hours, the therapist is actually seeing the kids in the school setting, typically about once a week. There's downfalls to school-based therapy. One of them is the lack of family involvement, which we know is really important in child's success and behavioral health treatment. The other one is it is a little disruptive to the child's school day, is that the therapists are there seeing multiple kids a day, and they can't always work around kids' lunch schedules, study hall schedules. So they are getting pulled out a little bit of their academic time, but I think it is a really nice way to meet families' needs when we're not able to get them in outpatient therapy or other levels of care.
Another important thing to remember about both SAP and school-based therapy is that a child cannot get full access to all of these services without permission from the parent.
Right.
It doesn't matter what their age is, actually. There's maybe some flexibility over age 14, but because it's different than behavioral health a little bit because they're school-based. So if you have a child that you feel like should be getting school-based interventions, they're in the school and they're not getting them, it might be reasonable to say to the family, well, first of all, if they reach out, they'll get them. But it may be that this is a family that for some of their psychosocial reasons haven't been able to answer the phone, haven't been able to sign off on sort of giving them the services, and that there may be a disconnect between what the school can provide and what they're getting. So it's important to recognize that they can't give those services without the parent saying it's okay. And if we know we have lots of parents that don't answer the phone, and if a school doesn't have someone that can go to the house, which many don't, that's where a huge disconnect happens in some of the kids that have the greatest need, and where a pediatrician or primary care doctor can really intervene and get the parent responding to the school.
And sometimes families say no because they don't understand what the school's asking or providing, and so a lot of care coordination that we do through TIPS is educating families on levels of care, because sometimes the resistance is just because they don't understand what we're recommending or why we're recommending it. So I think it's important to think about that as well. Finally is the school-based partial hospitalization program. So these are actually embedded in schools, and they're not available in all schools, but they are available in many communities. As an outpatient provider, I can't refer to a school-based partial hospitalization program. The referral is really internal through the school, but we can advocate for those. They're often much longer stays than the acute partial hospitalization programs, and they're getting, again, same as the partial, they're getting their education and behavioral health needs met at the same time.
As we wrote these, we were just commenting that we're starting to see more and more of these programs embedded in the schools instead of just having these alternative school programs, because the laws in the state changed and the districts get more money for having a child in their building. Mm-hmm. And unfortunately, money does drive a lot of behavior. I think this is a good behavior to have more services available in the school. But what may happen, and actually this has happened in the past, is that we may see different criteria and different sort of programs developing in each school. So there are more services starting to be developed in schools over the last couple of years, and I see that increasing over the next few years.
The next one are the community-based, and we won't spend a lot of time on those. We have the BHRS. I think it's just a language to be aware of. Families might talk about having a BSC. The definition of that is there, a TSS or an MT or mobile therapist. Those are all considered under the BHRS umbrella. A higher level of care than BHRS would be family-based mental health services. This has more evidence to support it, and there's typically 2 master's level clinicians that come in and really work with the family. An important component to remember is that family-based includes family therapy, case management, a lot of advocacy, and they also have a 24-hour emergency crisis intervention component. So kids that have family-based mental health care, if they're in a crisis in your office, you're not contacting your community crisis team, although you could and they'll connect you with the family-based team, but knowing that these kids there's a 24-hour crisis component built in to the family-based program, I think is important to make sure families are aware of. And then we just included the MST, multisystemic therapy, which is an intensive family-focused community-based program that many communities have. We just want to make sure you're aware of that.
So something to remember when we're talking about all these services that may be popping into some of your heads is there are evidence-based interventions for autism that work for behavior. For example, ABA or behavioral interventions are shown to be specific types of therapies that are shown to be effective for autism. There are also specific behavioral interventions that are shown to be effective for non-autistic disruptive behaviors. And those can be administered through the BHRS system. So you could have a BHRS system that's got ABA-trained providers or have providers that are trained in specific evidence-based interventions. And that's good, right? But it's not necessarily a given. So there's a lot of variability in the BHRS system. And there's some disconnect in our state right now, actually across the whole U.S., that the people that are approved to do ABA that have gotten that, a lot of them that have gotten that certification aren't actually licensed clinical providers, so they can't bill. So there's some weird disconnects going on in our services that hopefully will get fixed in the next few years. But these are things that families can ask, that you can help advocate, have your families advocate for themselves so they're getting BHRS, like what are their providers trained in? Is their mobile therapist trained in a specific intervention? There are also family-based trainings. There's one that most of our providers that I've seen in the state are trained in, where they actually have to take a certification, they have to take a test, they have to do a certain amount of work before they call themselves a family-based team. And the families can certainly ask, have you had the certification in family-based? So you know you're getting people that are actually providing the evidence-based treatment.
And then the final one is the out-of-home placements, the diversion and acute stabilization program. These are temporary, up to 28 days. Typically, exactly what it means, a diversion from an inpatient hospitalization. Sometimes they also are used as a step-down out of an inpatient hospitalization. The RTF, again, the longer treatment program, and like Dr. Schlesinger had mentioned, these are difficult to get approved, but there are kids that really need RTF to be able to improve with their symptoms. And then finally, the acute inpatient hospitalization, which is obviously the most intensive level of care. And we often talk about the difference between 201 and 302. So 201 is a voluntary inpatient admission, and a parent can sign a child in as a voluntary admission. A 302 is an involuntary hospitalization where someone outside has made a decision that this child really needs evaluated in an inpatient setting. So those are just the 2 different ones.
So the next thing we wanted to talk about when we talked about care coordination, since paying for treatment and getting appropriate interventions and getting higher levels of care often comes up, is PH95 medical assistance, which is frequently referred to as the loophole in sort of lay terms. It is true that many private insurances do not cover higher levels of care like BHRS and family-based or RTF. And in order to get them, you have to have Medicaid. In our state, since I believe it's the 80s, you can get Medicaid if you have several diagnoses. It's not just behavioral health, although we frequently use it on the behavioral health diagnosis world. This actually came out of a group of families, I believe in Philadelphia, sued the state because they had to give their children up in order for them to get the appropriate treatment they needed. So the family sued the state. The finding was that the state had to have a mechanism to get kids treatment so that they could stay in the least restrictive environment, which is with their family. Not every state has this, and in fact some people move to this state to get access to these services. And once you qualify for the loophole or the PH 95, it doesn't matter how much income you have. You can have access to Medicaid services. Families can apply on their own. They actually don't need you to initiate it, but they will need you to write a letter at some point, which is documentation of a qualifying diagnosis. And if people have private plus Medicaid, we often call that secondary coverage. So their primary coverage, say it's Highmark or UPMC or Aetna, they cover the initial, they cover things that they cover, and then the Medicaid kicks in when they don't cover anything else. It is true that in Medicaid, you can't have copays. So they also make sure that you don't have copays along with your medicines. Now, that being said, Medicaid is a very large entitlement, both in the state and in the United States, so it does have prior auth associated with it because of that. So that may be why there's the perception that behavioral health has more prior auth, because you're having more kids on Medicaid, and Medicaid has prior auth associated. And anything that's so big of a part of the budget is going to have some sort of cost controls set in place. This Compass site, you can go on and apply. It is a little bit confusing. It's gotten better. I'd actually say I've seen it get better over the last 5 years. A question that I often get from doctors is like, just tell me what diagnoses qualify, and it's just not that simple. Although I can tell you pretty much any patient you see with a behavioral health concern who's impaired, who qualifies for any diagnosis that we're used to, ADHD, ODD, autism spectrum, anxiety, depression, I can go on, is going to fit in the criteria. So I actually tell doctors, don't worry about it. Write your diagnosis and say they're impaired. It really should come from a physician, although certainly we've seen examples of social workers and things writing that a physician is given the diagnosis. And we just put this on here to show that we're not really making it up, that it's a little more confusing than just giving a list. So Social Security has made a list of who qualifies. These are the areas that the diagnoses fit into, and then there's like, I don't know, 15 to 100 diagnoses under each of these areas. And so remember, these diagnoses run all the way from diabetes to autism to dementia. And in fact, it's not even entirely clear to me which one of these categories ADHD fits in, but I can tell you it does, because I have definitely gotten people to get PH95 because they were impaired, significantly impaired by their ADHD diagnosis. We've been asked to give an example of a letter. I don't know whether this is a formal letter, but I would say this is actually what I've written. I've diagnosed Grady P., that's the patient, with ADHD. He is impaired by his symptoms and qualifies for the PH95. It's pretty basic. It doesn't need to be extensive. If there are questions, the Medicaid, they will initiate an additional evaluation. You don't have to do that. They may ask for forms. They may ask for, not forms completed, but often they'll ask for additional documentation like fax to them. If this isn't getting disability, although that's the standards they use, this is getting Medicaid loophole. That's an important thing to remember. I've had a lot of families say, I don't want my child to have disability. I don't want them to be on disability. I got to say, frankly, I try to avoid people getting disability as long as possible because the evidence is once you get disability, it's hard to get better. So this is getting additional support so that you can get interventions paid for, essentially.
And families may come to you, it is part of the process. They are required to apply for disability as part of the PH95 application. Most of those kids will get denied, and if a family gets a denial letter, it may be because they're being denied for Social Security disability and not because they're being denied for PH95. So we often will get those questions here as well.
So release of information, let me start by saying that this could be an entire series just about release of information and what's personal and behavioral health versus physical health. So we just wanted to highlight a couple important things. We're obviously not going to dig deep into all of these things. That you really should have 14 years or older kids signing the behavioral health release of information. Once they do that, that belongs to them. They need to continue to sign for it. You need to have a release of information that specifies behavioral health and drug and alcohol information. And if you don't, you'll get into a weird position where people will be able to tell you about one thing, not the other, and that gets really confusing for behavioral health providers. The dates of treatment must be included. We learned this in the last year that you can't actually sign for the future. It's odd, but that actually you're supposed to be signing for past treatment. Many times people don't hold you to that, but if someone really has a center that's being evaluated on whether or not they're following the HIPAA and the privacy laws for behavioral health, they will. And generally it's valid for 90 days unless otherwise specified. It cannot exceed 1 year. And consent can be withdrawn at any time. And it doesn't need to be withdrawn in writing. Someone can just say, I'm withdrawing consent. So release of information is also a stickity wicket. It's not required when disclosure is necessary to prevent serious, foreseeable, or imminent harm to a client or another identifiable person. This is our out when someone is suicidal, when someone is about to kill themselves in any way, shape, or form. Could include using substances. But the fact of the matter is most of our world is a lot more gray than that, thank goodness, but it makes release of information more complicated. So I would recommend that if you're uncertain about the need of release, do your best to get it and always consult your agency's compliance officer. And again, we're going to continue to talk about this in trainings. We've done it already and we'll do more. So who are your behavioral health allies?
So these are really quick, but I just wanted to make sure you have that information, is that if a child has a medical assistance in the state of Pennsylvania, they have a behavioral health managed care organization, and there's a link there to figure out what counties are covered by what BHMCO, and these are, they can be very helpful resources to families as well as you as providers. I always like to let people know that every county in the state of Pennsylvania has a CAS coordinator, and those CAS coordinators are what I consider the expert in their county on levels of care. So as Dr. Schlesinger and I went through the levels of care, if you're unsure what your county has, your CAS coordinator should be the person that should answer that question for you. And there is a link there to every contact, email, phone number, to every CAS coordinator for every county. I also suggest to a lot of pediatric primary care providers and family providers that they get to know their county crisis services. Ask them to come over for lunch maybe once a year and know what their referral process is. Do they have mobile services? Do they have walk-in centers? When should we call you? When should we not? When, do you have cards that we can provide families that come in? It's really good to know who those people are. And finally, of course, tips. Call us. We really don't want to get the word out. We've heard some providers say, well, they're busy, we want to bother them. Bother us. That's what we're here for. Call multiple times a day. And if you're not sure what your TIPS team is, there are 3 teams across the entire state of Pennsylvania. That link will show you who your team is and what their contact information is.
And if you happen to call one TIPS team and for some reason it's not actually your TIPS team, we will connect you to the other one. We've done that for people on our border multiple times.
Absolutely.
So there is no wrong. Call any of us and we'll get you there. I'm going to pass this off to Renee Turchi.
Great. Thank you, Dr. Schlesinger. I know we're coming up against time, and I just wanted to highlight some of the work that the chapter is working on. It also kind of ties some of this together. There's a great overview of a lot of the behavioral health services. And one of the things that's going on right now from a policy perspective is Connell O'Brien has convened a group called the Coalition for the Common Health. That really the goal of that, and Eileen Thompson, who's our director of our medical home program, and myself sit on this committee, and it really is a great collection of folks really looking at transforming health and looking at integration of behavioral health and physical health. And we've talked a lot about this definition of whole person primary care, and so there's just been a lot of discussion at a policy level connecting the dots through a lot of the things that we've talked about today. So we wanted to highlight for you that a lot of this is going on at folks in Harrisburg. And also wanted to highlight for our medical home practices that we are working with the National Center for Care Coordination, the HRSA-funded center. Dr. Rich Antonelli, many of you know, there is a new care coordination curriculum that's being launched, and so we are going to be working on that with some of our practice teams. There certainly are things in there with behavioral health integration, touching on a lot of the things that Colleen and Dr. Schlesinger mentioned today. So we're hoping to be able to bring that to our practice teams and network to kind of bring some of this to life or help support any new members or look at quality improvement within your practices. So we wanted to highlight that that was also available. I don't know if anyone has any questions. I know we're right up at the 1 o'clock hour. If anyone wanted to type a question in the Q&A box, we can take some questions. Be sure to hit pound 6 if you wanted to ask a question. We could stay on for a couple of minutes, and if the folks do have to leave and aren't able to ask questions, if you email Eileen Thompson, we can have those questions addressed.
We do have a question. Someone is asking, what if the patient has a diagnosis, but it was not made by the PCP, but made by another provider outside of the PCP office?
We'll take that one. So if they have a diagnosis and you agree with the diagnosis, you can, as a physician, as a provider, you can say that they have this diagnosis. So as long as you agree with the diagnosis and confirm it, you don't have to actually be the one that did, like, say the A to us or anything, as long as you agree with the diagnosis. Certainly if you don't agree with the diagnosis, I wouldn't do it because I think that's unethical. But if you agree with the diagnosis, it's completely okay to help them with the letter.
Great. At this time, due to time, we are going to conclude our webinar. We want to thank Dr. Schlesinger, Dr. Turchi, and Colleen Gianneski for their excellent presentation. Many thanks again to the Pennsylvania Department of Health for the funding that made this webinar possible. And again, if you have any further questions, please feel free to email us at ethompson@paap.org, and we will be sure to address your questions. Thank you very much.